Hello all, good evening. So welcome to the second lecture of Med Clinics. Orthopedics, we have done general examination of all the joints, right? If you remember. And now today we are going to deal about one more interesting joint. So today we are going to start the individual joint examination, right? I know we have missed one class in between. So today I have come with one more interesting joint examination, that is examination of the knee joint. Okay, so before that, am I audible, visible to everybody? So should we start or wait for some people to let in? You have just completed your foray surgery class by Dr. Sandeep. Okay, done. I'll just keep starting so that people will keep joining. So today we are going to learn in detail about the examination of the knee joint, and to tell you that this is one of the most important joint examination when it comes to your fourth year viva, right? And your fourth year practicals and viva, there are very important things to be done in the knee joint. And usually whenever there is an examination of the joint, it is a short case which will be given to you, and the examiner will expect everything to be known by you, because most of the surgeons and most of the people who are practicing also will be well versed in knee joint. So you have to be, whenever it is a knee joint case for you, you have to be extra careful, because people tend to ask you more questions, because we usually deal more with the knee joint in practical and in our practice also. So that is an a natural thing to ask more questions in subject what we know more, right? So today we are going to learn that in detail. And whenever somebody is giving you any examination of any particular joint, it could be, the reason of this could be either the patient had come to the hospital because of a trauma, or because of any cold condition where the pathology already existing in the joint. So it could be called as a pathological joint, right? So you have to first differentiate whether it is a traumatic joint or a pathological joint. Based on that, some few extra findings and some few extra things to be added, right? Clear? Okay, so let us assume that now today we are going to examine the knee joint. So for example, let us take, we have given a case of osteoarthritis. That is the first case. And second case, let us assume that we have given a case of some IDK. What is IDK? It is called the internal derangement of knee. It is an old term which is mainly related to the any damage the internal structures of the knee, right? So it could be damage to the ACL or MCL or LCL. So these are the important structures, like the stability of the knee joint. So whenever there is a damage to the important structures, we put we this is a specific like terminology which is given as EDK, so that you know which you specifically doesn't know which one injured, but there could be some injury to these structures. That is called internal, right? So this could be one of the it is not actually the diagnosis, so it could be for telling that the knee is injured, right? So let us assume that one we are dealing with ONE, one with the IDK. So usually this IDK or internal derangement of the knee or any problem to the internal structures of the knee is probably because of some trauma, right? And this is a degenerative condition. So this is a degenerative condition, right? So we are going to discuss both in great detail. So why I'm telling you this in detail is because every case, whatever case you take, always starts with the first. Always you have to write the dermographic data. Hi Kalai, good evening. So what we were discussing is today we are going to discuss about the knee joint, right? So because Kalai has just come, I'm just repeating few important things. So this today we are going to deal about the examination of the knee joint. As I have written it clearly here, this is very important when it comes to your practicals. So this is one of the most important case which they would usually search for the fourth year students, and most of the examiners who come for as your internal or external examiners will be well versed with the knee joint. So they could probably ask you more questions related to this. And whenever you see any case, especially today as we're going to discuss knee joint, so this could be because of the problem of the knee joint, or the symptoms of the knee joint could mainly be because of trauma or any other condition where the joint is already compromised. So this is called a pathological joint. So we are going to deal about the knee joint, whether it could be a trauma related case or it could be a pathological joint, right? So any case, we would start directly with the demographic data. So in this data, so first is always the name, as we have already learned. Then it is the age and the sex. So now you tell me how age is related. How is age is related when it comes to your knee joint examination, right? So this age can play a very important role for us to diagnose between rheumatoid arthritis of the knee joint and your degenerative arthritis, right? So as you all know, this rheumatoid arthritis is usually in young females, and degenerative is usually seen in older. It could be more in males compared to females, right? Hi Shiv, hello, welcome to the class. So that is how we will want to know what is the age of the patient, because whenever a patient presents with either rheumatoid or degenerative disease, for example, if a patient is somewhere around 45 years old, now what comes to your play? Now what comes to your rescue is whether it is polyarthralgia. So whenever somebody says polyarthralgia, then again it goes to rheumatoid, right? Right? So that is how the demographic data is important for us, right? So first we have to ask the name, then we are going to ask about the age, then about the sex. Sex usually doesn't play a very important role, except for again for the rheumatoid. Usually it is seen in females. As we all know, autoimmune diseases are more common in females, right? And one more thing, where sometimes in males, so what are the two important things which you have to remember? One is hemophilia in case of knee joint, and the second one is uric acid, right? Sometimes in males they may have effusion of the knee joint, right? Effusion of the knee joint could be a case for you, and then you have to diagnose it. There it plays an important role. There usually, if you want to diagnose it, we usually tend to see more of increased uric acid levels in case of. So that is how sex plays some important role in few of the conditions, right? And and especially when it comes to knee joint, occupation is very important, because as you all know that the knee joint is one of the strongest and one of the most important weight bearing joint, right? So for this you have to know the what are those activities what the patient does. So these are mainly important to know the activities of the patient, and you have to know whether they are athletes, because most of the knee injuries are common in case of footballs, that is football players and coal miners. Yes. So this is how the occupation plays a very important role. Yes, for football players, as Kalai has brought up O'Donoghue triad, let us make one thing very, very clear. So what is O'Donoghue triad? Kalai, what is O'Donoghue triad? So as you all know, there are certain important structures of the knee joint, right? So whenever there is a damage to the MCL and whenever there is damage to the ACL, and now comes the most interesting fact. So previously it was told that the medial meniscus was the one which was involved in this O'Donoghue triad or O'Donoghue unhappy triad. Now they have done a lot of research and they have put up that the lateral meniscus is involved. It's a recent update. So I want you all to even note it down. So it is no more medial meniscus. It is the lateral meniscus plus MCL plus ACL. Right? Got it, Kalai? So when it was in the olden days, we even when I was in my postgraduate also, I have learned it is a medial meniscus only. But now recently, maybe from past 3 or 4 years, what they have done research and they have found out the injury which is, I mean, the mechanism of injury which is required for MCL and ACL tear will result in damage to the lateral meniscus, right? Not to the medial meniscus. So this I want you all to update, because any new updates will be asked in the INICT exam, right? As you all know, the National Institute exams, they'll mainly focus on such points. Yes, it is a new info. Now I want you all to be upgraded with it. Okay, good. So that is how Kalai has brought us one important fact. So where are we? Okay, back to our demographic data. So name and age and sex. Why am I telling you in detail? Because see, sometimes examiner's mindset will not be in such a way that they don't directly ask you, tell me palpation, tell me your palpation findings, your movements and all. Sometimes they will ask you how age is related. Why did you ask age in this patient? So for that, for you to answer, I'm putting all these important things, like whenever they ask you what is, how is age related to your history, or how is age related to this, you can see whenever you see examining a patient of 45 years, then you can say so and so diseases can be diagnosed with the age, right? And now whenever they ask you why occupation is related, why you want to ask about the patient activities, then you can tell if it is a trauma. You can tell if it is a trauma in such athletes. The mechanism of injury plays a very important role. What is this mechanism of injury? So mechanism of injury is something where the position of the foot on the ground and the forces acting on the knee joint, on the knee. So this plays a very, very important role for us to diagnose, right? It plays a very important role to diagnose. For example, you can also quote an example such as any lateral force to the knee joint will will result in the damage of a very, very important structure which is called as the medial collateral ligament damage, because any blow from the lateral aspect will cause damage to the MCL. Similarly, any force on the medial side will cause damage to the LCL, but this is most common. If you see, the medial side is protected by the other knee, right? So medial side is inside, the both knees are together. The medial side is usually protected. Nobody will come in between your knees and then do a blow job, like, I mean, not the blow job, I mean blow on the medial side. It could be as a result of any other sport activities, right? Any other sport activities. But lateral forces are very, 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 very common, right? So this will result in the MCL damage. So that depends upon the position and the forces acting on the knee. You can tell so and so can be damaged. Locking and unlocking of the knee, confusing. Yeah, I'll deal with it. Just once, I'll come when I come to locking and unlocking of the knee, I will tell you, right? Okay. So now this is the mechanism of the injury. So these are the very, very important things which you have to keep in mind whenever you're taking the general data. It could be very easy, like just ask the name, age, what is the active occupation of the patient, and all. But each one is significant. That is what I want you all to remember. Then comes to history taking. So once you finish the demographic data, I mean, once you finish all those important things, identifying the patient, same patient are you taking, which was given to you and all, you have to always start with the chief complaints. You have to always start with the chief complaints. So here in the knee joint, what would be the chief complaints? The chief complaints would mainly be the pain in the knee joint, very, very important, or it could be a swelling in the knee joint. And then you have what is called as deformity in the knee joint. So all these are cases for you. So any pain in the knee joint, if they diagnose, it could be a simple ACL tear or MCL tear, then they would give you as a case. If there is a swelling in the knee joint, especially whenever it is a hemarthrosis, and whenever it is, any swelling in the knee joint, simple effusion also, they would give you as the case. And then very, very important, deformity in the knee. So usually what they give you is the varus deformity. Varus deformity. Yeah, swelling, stiffness also sometimes they would put. That stiffness is nothing but again it is a form of a deformity, right? So these are all the important chief complaints which we'll have. And it is not important for you to tell that it should be in the chronological order. I know you will be very, very well versed with it, so you have to take this chief complaints in the chronological order. Then comes the history of presenting illness. So giving away of the knee joint will be something related to history of presenting illness. Nobody will come and tell you that it is, and it could not be a chief complaint. The chief complaint would be first pain and instability. Instead of giving away in the knee joint, you can tell the patient is complaining about the instability of the knee joint, right? Instability of the knee joint. You have to be very careful about the words also. Okay. Now, history of the presenting illness. Now, history of the presenting illness, you are going to elaborate everything in detail. So as you all know, pain, what to ask, what is the onset, or what is the duration of the pain, how severe it is, and how is it radiating to any other joint. So all these things you will ask in case of pain. So first you will start with onset, type of pain, duration of pain, right? And most important thing in our thing is the radiation, whether it is radiating to any other joint. Like sometimes the hip pains, as I've told you in the further class, we have done pediatric, right? In skiffy, the problem is in the hip, but the pain will radiate to, in skiffy, where is it radiating to? Yes, Kala, where it is it radiating to in skiffy? Yes, it will radiate to knee joint. Very good. So now the patient might come only with the pain in the knee joint, but probably the pathology is not in the knee. So this is why you have to take all the relevant characteristics of the pain, right? And aggravating and relieving factors and associated complaints of it, whether it is with associated with the fever, whether it is not associated with the fever. But in case of trauma, whenever they say it is due to a traumatic injury, what is the one thing which you ask in presenting illness? That is the mechanism of the injury to be included. That is very, very important. So that is about the presenting illness, right? And one more thing is, usually in presenting illness, if it is of TB, if you're dealing with TB, arthritis of knee, Then what are the two important questions you put to the patient? So in orthopedics, what is the thing? The thing here is you put all the positive history together, right? You put all the positive history together. So once the patient has come to you, he says there is pain, there is swelling, and now you want to eliminate whether it is related to tuberculosis or not. Yes, one thing as night fever, that is nothing but your evening rise of temperature. And then quicker, evening rise of temperature, then yes, weight loss. Very good, Shiv. Weight loss is one important thing. One more thing, lymphadenopathy, you can ask the patient, but usually in TB, no, we have to examine lymphadenopathy. We examine. Sometimes they might appreciate, sometimes they will not. But this is the one which they appreciate. Most important thing: evening rise of temperature, weight loss, and no, I am asking about the history. Loss of appetite. Cough and all is only for pulmonary. No, I'm talking about TB arthritis in knee joint. So they might not present with cough and all. They have to present with weight loss, loss of appetite, evening rise of temperature, right? So these are the things which you have to keep in mind, because again the examiners will ask you, if it was TB, what would be the most relevant points? And if it is related to tumor, if there is some tumor, for example, a malignant tumor, then what would be their complaints? The arthritis is always secondary. Is to some focus, but that doesn't mean it is pulmonary and patient will have cough. They will never have cough and all in case of TB and TB hip. They will present only with pain and swelling and deformity in that particular restricted movements in that particular joint. Yeah, tumor again, there will be loss of weight. Yes, loss of appetite. Yes, and sometimes they may present with swelling. Good. So this is how you have to differentiate with the following complaints of that patient. And once if it is deformity, if they say only there is deformity, for example, there is an OA patient like osteoarthritis of the knee patient has come with varus deformity. So what all relevant questions you will ask? So they have told you there is a pain, severe pain, and pain is more in the, when will the pain will be more in OA? OA matlab it is osteoarthritis. Pain is more during which time? Diurnal variations of pain in case of osteoarthritis. Yes, very good. Evening, there will be more pain. Why evening? Because the pain increases as they work. So at the end of the day, if it is RA, so similarly, a patient pain in the knee has come and she's a young female. So when, yeah, after overuse, yes, after overuse. And for RA, it is, the pain is more in the morning. Yes, pain is more in the morning. And this is also called as morning stiffness, which is usually more than 1 hour duration and decreases with activity. Right? Inflammatory pain, early morning stiffness. Very good. So RA is an inflammatory condition, OA is a degenerative condition. So these are certain things which you have to put in mind, right? So for trauma, always remember there would be mechanism of the injury. So how they did fall, whether it was a twisting injury, whether it was a direct injury. So you have to ask those relevant questions. And once you have finished taking these important questions, and for if it is infections, very, very important. They usually ask you infections, right? So infections, what are the important points? Yeah, this could be because of the in RA, it could be because of accumulation of the inflammatory products over the night, because there would be no activity, and there would be a lot of inflammatory products which could be accumulated in the joint, which will result in pain in the early morning. Very good. Then if it is infections, yes, no, local rise of temperature and redness, it is usually the signs what we doctors elicit, right? What would be complaints of the patient? We are still in the chief complaints. If it is infections, what are the relevant points you have to put in the chief complaints? One will be pain, and the second one associated with the very, very important, associated with fever, right? So whenever they talk about the infections, this is about the suppurative infections. Suppurative means bacterial. Acute infections, usually they will be associated with the fever. Again, there would be some amount of loss of appetite for the patient, right? And of course, swelling, that is effusion of the knee joint. So now whenever you see that there is a patient who is complaining about pain and swelling, and then there is a rise of temperature, that is fever, and usually this would be high fevers, high grade, right? And in case of TB, it is this fever. In case of tuberculosis, it would be a evening rise of temperature. This would be a low grade fever. You have to always remember, for tuberculosis it is a low grade fever, right? In tuberculosis it is a low grade fever, whereas in your infections it is a high grade fever. Okay, so is that clear, guys? Yes, that completes the history taking, and by the end of the history taking you have to come to one diagnosis, a probable diagnosis. So whether it is a degenerative, whether it is a infective, whether it is trauma, or whether it could be a metabolic, or whether it would be a tumor condition. Okay, these are all the possibilities. So once you come a conclusion at the end of the history taking, right? So for example, now we have come across the OA. For example, we were taking osteoarthritis of Nino. By the end of this history taking, it is osteoarthritis. Then now you know what points to look in the examination, what points to put in the examination. So by the end of the history taking, there should be some diagnosis in you. So at least you have to categorize it, be degenerative or infective or traumatic or metabolic or tumor or a inflammatory. And finally, sometimes it could be congenital. Usually they don't give you congenital in the examination, right? So you have to put a subtitle, right? So which case you are going to examine, right? So now let us start the examination. So now the patient role is done. Patient has told you the relevant information and you have asked all the positive points. So mainly giving away is mainly given for the term ACL, anterior cruciate ligament tears, will usually give rise to this giving away. That means they feel instability, and then you have to examine for that. Okay. So first diagnosis is, most common diagnosis for giving away is ACL tear in middle-aged patients if there is some trauma involved in the knee joint. Okay. Okay, now let us come to examination. Is that clear, Shiv? Okay, now let us come to the examination. So examination of the knee joint will usually start with the gait. So what are the important gaits you see which is related to the knee joint? The first one would be limping. That is, the patient lurches to normal side. He lurches to normal side so that the pain is relieved on the affected side, right? pain is not felt on the affected side. So that is called the antalgic gait sometimes. So this is the most important. The pain comes limping, and you can see that attitude will be flexion of the knee usually. So why it is flexion of the knee? It is mainly seen in effusions, any swelling, because this is the comfortable position of the knee. So something to accommodate. What is effusion? What is swelling of the knee because of fluid? Now, what happens is whenever there is some problem in the knee, there would be synovial irritation, and this synovium will secrete synovial fluid. So this fluid has to get accumulated, or it should be accommodated into the knee joint. So for that accumulation or accommodation of the thing, what it does is the knee goes into flexion. Right, so the knee goes into the flexion, right? So this is the attitude. Most commonly seen attitude in the knee joint is flexion of the knee joint, right? Yeah, very good. What accommodation of the hip? Whenever you say hip joint accommodation, it is flexion, abduction, and external rotation, that is Faber, where the hip is, it can accommodate the synovial fluid in the hip joint. Yeah, knee, these OA patients, they will have knee flexion position, but whenever there is the swelling of the knee joint, and later periods, because of the deformity, because of there is some problem in the knee joint, the mechanics of the knee joint will change, then they will have slight flexion, and they will have, right? It will depend upon the stage. Initial stage, it is because of the swelling of the knee joint, the knee goes flexion. Later stage, because of the contractures, the knee might go into flexion and varus deform. So those, that is called the deformity. This is called the attitude. So what is an attitude? Attitude is nothing but a comfortable position of the knee. What is the meaning of attitude? It is the comfortable position of the joint, or position of ease, right? Is that clear? Right. Then these are the two things which you have to put in mind. So first, whenever you see a patient, first is exposure. You have to always remember, I just forgot to tell you that exposure is, now we are going to expose both the knees. So that is, you have to put both the knees, uh, patient will be in supine position lying on the couch, and now you have to expose both the knee joints, that is up to at least half of the thigh, right? Half of the thigh. The clothes should be removed, or the pajamas, whatever, they have to be pulled up, so that you have a complete vision of the knee joint from all the aspects, from the top angle and from the medial aspect, lateral aspect. And you have to turn the position patient also in the prone position to examine the popliteal fossa. This completes your inspection, all around inspection. 3 of inspection of the joint is very, very, right? So you're not going to neglect the popliteal fossa, right? So that is the inspection. So first starts always with the exposure. Then sometimes if the patient is able to walk, you examine or you observe the gait of the patient, and then the attitude. So attitude most commonly to the flexion of the knee joint. And what is the one more important attitude you have to remember in the case of the knee joint? It is called the triple deformity of knee. What is triple deformity? You can have dinner while watching the show, right? Nicely have dinner, don't, no problem. You can nicely have dinner while watching. Instead of watching your Insta and scrolling, you can, or your TV or something, you can watch the video and eat. Multitasking. Yeah. What is the triple deformity of the knee? So triple deformity of the knee is one of the important deformities. So whenever somebody is talking about the deformity of the knee joint, one is the flexion deformity they talk, and then is the triple deformity. And it is a very, very important question. And if you answer this, you're going to get extra points, right? So what is a triple deformity? First is the flexion. Then is the posterior subluxation of tibia, flexion of the tibia, posterior subluxation of tibia, and external rotation or lateral deviation of, right? So this is the triple deformity of the knee. And where it is usually seen? What are the areas where triple deformity is seen? I mean, what are the conditions where the triple deformity is seen? Yes, very good. It is TB knee, rheumatoid, polio, so it is tuberculosis, arthritis, tibial band contracture, and then it is polio, and then it is. So please remember, so if somebody is asking you the triple deformity of the knee, very, very important, even in the NEET PG. So if something is in 3 numbers, so they can ask you which of the following thing is not seen or triple deformity. So there is flexion, there is posterior subluxation, and there is external rotation of the tibia. And then you see what is called as in tuberculosis, in rheumatoid arthritis, and then you see case of your iliotibial band contracture, polio, and hemophilia. Right? Yeah, polio, hand on the knee gait because of hand on the knee gait is happening because of what? You have to know the pathology also, no? Because this is a wasting of which muscle. This is how leading questions happen in the Viva also. So when, yes, it is quadriceps weakness. And when you know the answer, it is very, very good. I mean, you can lead the examiner to that point. Okay, because of the quadriceps weakness in case of polio, which is very common, patient will have hand to knee gait. And what are the triple deformity expected? It is expected in case of tuberculosis, rheumatoid arthritis, iliotibial band contractures, polio, and so these are the areas where we can see the triple deformity. And what is that deformity? The knee goes into flexion. So this is your triple deformity where the knee goes into flexion. And then you have posterior subluxation. That means the knee goes backwards. And then you have lateral deviation or the external rotation of the tibia. Right? So this is the triple deformity of the knee. Very, very important in asking, I mean, they can ask you as a question. Right? And then that is about the attitude and the deformity. Your attitude, it could be one of the triple deformity. Then comes the swelling. So if there is any swelling or the effusion on case of inspection, you have to tell the, I mean, you have to inspect it, the swelling, where is it present, how is it, is it full, or what is the shape of that swelling. So this shape will tell you whether it is an intra-articular or an extra-articular swelling. Right? It is an intra-articular swelling or an extra-articular swelling. So how do you know it is intra-articular or extra-articular? So there you have to look for patella. So if the swelling is a horseshoe shaped swelling, above the patella, then it is usually intra-articular. Then it is usually intra-articular. If it is an extra-articular, it usually covers patella and patellar tendon. I mean, extra-articular means it can be usually any swelling over the knee or any, cellulitis of the knee, the infection of the skin over the knee. So this whatever the swelling is there, you cannot see the patella. It will cover whole of the knee joint. But whenever it is a horseshoe shaped swelling which is present above the patella and both the sides of the patella tendon, or either sides of tendon, then that is a intra-articular infusion or intra-articular swelling. So most common intra-articular swelling, it could be a hemophilia, or it could be just a traumatic in effusion, right? Or it could be hemarthrosis, again due to trauma, or again due to some other injury to the intra-articular structures, right? So you have to comment upon this swelling and the deformity on inspection itself. And then comes the muscle wasting. So we have already spoke muscle wasting. For example, in case of polio, they said it would be a quadriceps wasting. And in case of TB, you will again see there is a wasting of quadriceps, right? So this is called muscle wasting, and this is in chronic. Muscle wasting means it is a chronic issue. So whenever you see a muscle wasting, it is a chronic issue, right? So you have to document even that there is a muscle wasting of so and so thigh or so and so part of the thigh, right, which you observe on the patient, right? And then, so what is this? So this is the swelling of the knee joint. So this swelling, if you see, so if you see this particular swelling here in the knee joint, it is usually above the patella like this, right? So this is the swelling of the knee joint. So this is the effusion. So you have uh, completed reading all this stage, Patonian. That's very great to hear. So this is the right side knee effusion what we see, and this is usually a unilateral effusion, right? Unilateral effusion. So the causes of this could be a trauma again, unilateral. So if it is bilateral effusion, then what you have to think of one condition in case of bilateral effusions? Yes, Montage, can you answer? What is the one condition where you think of bilateral effusions, bilateral knee effusion? So usually we have to think about, so you should usually we think about hemophilia, and one more important thing we can, in like it is not very common, but that is in syphilis, right? This is called as Clutton's joint. I'm asking about effusion, swelling, metabolic disorder. What swellings you see? Those are deformities. What we see in metabolic disorder. In infections, you see bilateral swelling. Then you have to go and read your first year again. So guys, okay, now let us not deviate. So this is the unilateral effusion what we see. This is because of trauma, as I've mentioned again. And most importantly, it is because of trauma. And here it could be of infections, the septic joint, because of bacterial infections or TB. So these effusions can be seen. And whenever you see or appreciate bilateral effusion, especially in males, you have to be careful. This could be an hemophilia. And one more thing is, you can just remember this as a theory bit. If they ask you in the practicals, viva again, the one thing is, so one thing we have to remember is syphilis. That is, it is also called as Clutton's, right? So that is about the effusion. And what is this? This is what I want to tell you. This is a hemophilic joint. So this is the hemophilic joint, right? And and you can see this is an example I have bought it to understand what is wasting. So this, you see, the thigh is very bulk here, and when you see the bulkiness of this thigh is reduced, so this is called the atrophy, and this is called the wasting. Atrophy and wasting. So you can, so for this, what you have to take, you have to for confirmation of this atrophy or wasting, what you do, we take circumferential measurement, right? So we measure at the thigh and at the leg. So this, by this we can document the atrophy or wasting. This is on, we are still in the inspection, so you will just document that there is wasting in quadriceps, right, or wasting in the leg muscle, that you will do. But how, when they ask you how do you confirm it, you confirm it by the circumferential circumference. Right there you take the measurement circumferentially with circumference, and you will tell, compared to the opposite thigh, this circumference reduced, hence a confirmation for wasting of the muscles, right? So that is about the inspection. And one more thing, if there is infection, you can write skin over the swelling. So this completes your infection. So this is what you can document, is about the sinuses or any tracts, or it is shiny in case of swelling, or any redness. So these all you can document in case of skin over the swelling. So 4 points you have to remember. So you always start with the gait. Always, then you come to the attitude, and these are the important points you have to remember in the attitude. And then swelling or deformity. Swelling, usually you write whatever you look. I mean, like the swelling is present entirely diffusely over the knee joint. So that is how you comment, and then you comment for the muscle wasting, and finally you will tell the skin over the swelling, right? So that completes the inspection. Then comes to palpation. So once you have confirmed, once you have done inspection, everything of inspection should be confirmed by palpation, right? That is the dictum. So once you have come to a diagnosis, so now you will do inspection, and then you have to confirm all those inspective findings by palpation, right? So with, in this, we always start with touching the patient with the dorsum of the hand, or dorsum of the fingers. Why? So how do you do that? First is always the warmth. So dorsum of the hand has, most tendency to feel, because palm is thick here on the this side, palmar side, the skin is very thick. So dorsum of the hand, you can feel the skin is little bit, not very thick, hence you can feel the warmth. So whenever you feel any warm, or this is an indication of infection. That means we are commenting about the focal rise of, okay, montage. You can actually add to whatever you have learned, or you can add the details. You can just check what we are teaching is right or wrong, and you can answer a few questions so that you can revise your subject as well, right? Okay. So now we have completed the inspection. So those 4 important points you have to remember while doing the examination on inspection. Now come to palpation. So again, palpation, you have to take consent of the patient. So before touching the patient, you have to always take consent of the patient, and you have to tell that you are doing to, so you are going to do so thing. Like for example, you're going to palpate the tenderness, or you're going to palpate the swelling. You're going to perform few movements, complex movements, so that you will know where the pain is exactly arising from. So for that, you first start with touching the patient from with your dorsum of the hand over that particular area. For example, there is a local rise of temperature that indicates that we are dealing with the infection, right? And that too, an acute infection. right? And now this is associated with redness if it is a suppurative infection, right? If it is a chronic infection, no local rise of temperature. No local rise of temperature, right? So that is about temperature. Not to forget, this is very, very important point. Sometimes if you forget, the examiner will point out and tell you that what is the first thing you do on inspection. Okay. Done. And then coming to the next most important point is tenderness. Tenderness is nothing but a sign which is elicited by the doctor. Tenderness is nothing but a painful point, right? So this tenderness is elicited by palpating all the bony prominences. So you're going to palpate all the bony prominences of the knee joint. So you will start with the patella, then femoral condyles, then PL condyle, right? Not to forget the popliteal. So this would be the order. So first you always start with palpating the patella. So you have to palpate the patella. You have to feel if there is any irregularity in the bone, right? Or a pain. That is tenderness. If there is a patient is complaining about pain or if there is any irregularity, right? If it is a fracture, you can feel the gap. If it is a fracture patella, you can feel a gap, right? And then femoral condyles. This is very, very important. Again, in case of fracture, right? Femoral condyles, and sometimes any swelling or extra growth which you can palpate in femoral condyle. And tibial condyles, both the condyles, lateral condyle is more commonly injured, right? Yeah, they have asked about the biparated patella. But biparated patella, again, it is a congenital condition, right? Usually on examination, you will not find anything. You have to take an X-ray for it. Or sometimes you can feel there are two swellings, right? One above and one below. So there is nothing to confirm on palpation in biparated patella. That is an X-ray finding. Okay? And popliteal fossa. So what you all look for popliteal fossa? So popliteal fossa mainly is for your swelling. So two important swellings which you have to remember is the Baker cyst, which is called the Morgan's Baker cyst, and next is semimembranosis. Semimembranosis, cyst of semimembranosis. Okay, so these two are important things. And then there could sometimes be popliteal aneurysms. Popliteal aneurysms, right? So this is sometimes very, very pulsatile and all, very rare condition. Usually we don't see, but you have to always remember whenever they talk about the swellings of the popliteal fossa, right? So these are all the palpatory findings, right? Is that clear? Yeah, biparated, I have told, no, we cannot actually feel on palpation. That is only an X-ray. Whenever you take the X-ray and compare it to the opposite side, sometimes to rule out biparated patella. Okay. And now, so once the tenderness is done, you will palpate for all the important structures around the knee joint. So just let us think about what are those important structures around the knee joint. So we have finished the bony prominence, and one more thing is what you have to feel for is the most important structures around the knee joint. So you have to always put these structures in your mind. So that is your MCL, your LCL, your ACL, PCL, and your menisci, right? So whenever patient complains about any trauma, so you have to feel for all these structures. So where do you feel for this structure? So for MCL, usually we look for the femoral attachment, right? We look for the femoral attachment, right? And for the meniscus, you feel between the collateral ligament and your patellar tendon for the anterior horn. So if you remember the meniscus as two horns, right? So it is the anterior horn and the posterior horn. So to feel the tears in the anterior horn, you will palpate between. So this would be a patellar tendon, right? So they have removed this patellar tendon. So it is somewhere like this. And now you slightly flex the knee joint. And this is your tibial collateral ligament. And then you're going to palpate somewhere here. So this will give you exact the problem of the anterior horn. And if it is the behind your collateral ligament, then it is your posterior horn, right? This is your posterior horn. So now what you do, you will palpate somewhere here. So whenever you have a pain behind the posterior behind the tibial collateral ligament, that is your MCL, then it is a posterior horn of the medial meniscus. So that is how you will palpate for it. And ACL, not exactly you can palpate for it. Sometimes you can feel on the anterior aspect, tenderness over the anterior aspect especially, right? And these are the important structures which you have to even test by carrying out the examination of the knee joint. And as I've told you that you have to feel for patella and all the bony surfaces. And now not to forget the fibular head also. So here I will add one more thing, the fibular head, right? So these are all the structures you palpate, and now you come to a conclusion that where exactly is the tenderness present. And once if they tell you about the swelling, now we are going to describe the swelling in detail, like what is the high location, what is the size, site of the swelling, and then its extension. So it is extending from so and so position and all. And now whenever there is a knee effusion, so usually swellings is knee effusion, right, in case of knee joint. So there are two important tests which you have to perform. So one is called the fluctuation test, and second one is called the patellar tap, right? So these are the two important tests which we do. I know you are very much familiar with the fluctuation test, right? So any swelling, any cyst, also you do this fluctuation test. So what is that fluctuation test? You press. So usually what happens is the fluid in the knee joint gets deposits in the suprapatellar fossa. So there are certain fossas, so which is above the patella is called suprapatellar fossa. It is a huge one, and now the fluid gets accumulated there. And now what you do, you will give pressure over the suprapatellar fossa like that, which what is it doing here? And then you palpate, then you feel that fluid is felt on both sides of the patellar tendon. So that is your fluctuation test. And then what is your patella tap? Again pressure is given on suprapatellar fossa. So now what you do in the patellar tap, you give pressure on the suprapatellar fossa. That is what he's doing. And now what you do is you just press gently the patella, you press over the femoral condyles. And now because of the fluid which is present between the patella and the femoral condyles, the patella will bounce back. So that is called patellar tap positive. That is called patellar tap positive. So for this test to be positive, it should at least have moderate amount of effusion. So it should have moderate amount of effusion, right? And now if it is only a mild amount which is present, then what you can do is you ask, this is done in supine position, right? Both of these are done in supine position. And if it is a mild accumulation of the fluid, the patient is asked to stand up. So you do this in standing position. Standing position, you can feel the fluid. Now you can again empty the space where the fluid is present, and again after you remove the hand, you can see the fluid again seeping that space. So whenever there is a mild amount of fluid, you do it in the standing position. So this is again an important question which is asked by externals, like external examiners. So when you answer all this, so when you answer that knee effusion, what are the tests, you tell that is a fluctuation test, you tell patella tap, then you tell everything. Then they ask you if this is all because of the moderate amount. So when there is only mild amount of fluid, what will you do? Then you have to answer them. We do such tests. We ask the patients to stand and do, right? Is that clear? Okay, are you following? Clear? So that is about the palpation, right? And now what you have to remember is there is one more important case what they usually put up for the UGs is the Baker's cyst. So in this what happens is the swelling in the popliteal fossa. There would be swelling in the popliteal fossa. And this is nothing but a pulsion diverticulum, that is a pressure diverticulum of the synovium itself. So it is a pressure diverticulum of the synovium itself, which is present as the Baker's cyst. And what is the specialty of this? So on extension, whenever you extend, you can feel the swelling, right? And on flexion, the swelling disappears. Right, so this is very important point which you have to remember. So on extension you feel the swelling, and whenever on flexing this swelling disappears. So this is an example of the Baker's cyst which is present on the posterior aspect. Now you tell, now whenever you see this finding, no, you will write all that swelling is present on the posterior aspect. It is present, just below the knee joint. And what you can feel is that on extension the swelling increases in size. On the flexion of the knee joint the swelling almost disappears. So whenever you see such an thing, you can tell that the probable diagnosis would be a Baker's cyst. And then they will ask you what is the differential diagnosis of this. So the differential diagnosis would be semimembranous cyst. Right. So semimembranous cyst is also similarly in action. That is, it disappears on flexion and it appears on the extension. But the position, it is usually higher above the Baker's cyst. High above the Baker's, right? Above the Baker's. Okay, the position usually differs. Right, is that clear? Kalai, are you there? Lokesh? So this is about your palpation. So mostly we will deal in palpation with the temperature, the tenderness and the swelling. And now what you do, then you come to movements. So once the palpation is done, then you come to the movements. What are the movements which you can feel in case of your knee joint? So knee joint is supposed to be a complex hinge joint. So whenever I say the word hinge, there is only movement in one plane, right? Usually the movement will be in one plane. So here the movement is usually the flexion of the knee joint and the extension of the knee joint, right? Flexion of the knee joint and extension of the knee joint. And now, because I have told you that the knee joint is a complex hinge joint, on flexion, so once you do flexion, there are other two things which you can do, that is abduction of the knee joint and adduction of the knee joint. And then there is mild internal rotation and external rotation. These are all the movements which can be done in the knee joint, right? Which can be done in the knee joint. So one is mainly the flexion and extension, but on mild flexion, you can do abduction and adduction and internal rotation and external rotation. These are all the movements which you have to do. And here I want to tell you about the locking of the knee joint. So what do you mean by locking of the knee joint? So because of some problem in the knee joint, this could be because of the meniscal tear, what happens is the patient cannot extend the knee joint beyond a point, right? But can further flex it, right? So this is called the pathological locking of the knee because there is some problem in the knee joint. It could be a meniscal tear because of the presence of the loose bodies. So there could be locking of the knee joint. That means what happens is whenever you do flexion and extension, the patient will remain in flexion. He will not able to extend his leg. He will not able to extend his leg because the extension is restricted because of the presence of any meniscal tear or a loose body. Most commonly, it could be a loose body or meniscal tear, but he can again further flex the knee joint, but he cannot extend. This is called the pathological locking of the knee joint. So this is also one of the complaint which the patient gives you, right? And now during the movements, you can sometimes feel this locking the knee joint. So you have to be very, very careful with what patient you're dealing with, right? You can see in case of OA knee, there will be loss of terminal flexion, right? And you can see sometimes there would be in case of any deformity, there would be absence of the abduction or adduction or external rotation or internal rotation. So those all you're going to document, right? That is about the, you're going to comment on the movements of the knee joint, right? And then what is very, very important in case of knee joint is the special test. So once you have done everything, so you are always bounded to talk about the special test, especially in the knee joint, right? So these are the tests for instability. Test for instability. So if you see the test for instability, you have to always remember that these structures, ACL and PCL, what we have is, what are the tests we have for ACL and PCL? They are the sets of ligaments, right? Then we have the menisci. Yes, very good. ACL and PCL, we have the Drawer's test, right? So Drawer's test, you can see here, the knee is flexed to 90 degrees, right? And now I'm placing my two thumbs on the both the sides near the joint, and then all my four fingers on the posterior aspect. And now what I'm doing is anterior and posterior translation of the tibia, right? Anterior and posterior translation of tibia. And now I will check if the anterior translation more, then it is ACL tear. If posterior translation is more, then it is PCL tear. Why, you know? So ACL will act as an anterior restraint of movement of tibia. So if this is your femur, this is your tibia, right? So one is your femur, one is your tibia, right? So now the tibia should not come more forward than femur, right? Both has to be in contact. And whenever you see there is an more anterior translation, that means there is a tear in the ACL. So this is an indication of ACL tear. Similarly, if the posterior translation is more, if this is the posterior translation, right? So posterior translation is more, then it is your PCL tear. right? And now this is done in the 90 degrees of knee flexion. Now when the patient is in acute condition, that is if the knee is with pain or effusion, you cannot do 90 degrees, right? Then what you do? You do one more test which is called as the Lachman's test. Yeah, you can ask the doubt, Gia. Lachman's test. So what is Lachman's test? Lachman's test is done only in 15 degrees of knee flexion. So you just hold the fibula, you just hold the tibia, thigh in one hand, leg in one hand, and then you just to do this translation movement. Instead of doing 90 degrees, what you do is you just raise 15 degrees and do. So in this 15 degrees of knee flexion, if you have any increased translations, then again it is indication of your ACL tear, right? Yeah, where have you gone? Where is your doubt? And then, so this is your anterior drawers test. So now what you do, first thing, three important things you have to remember. So the first important thing is the foot stabilization. So the foot has to be stabilized, and this is done by sitting on the patient's foot. So the doctor, the surgeons will sit on the patient's foot so that the foot is stabilized. Then what you do? You put the thumb near to the joint line and then the four fingers on the hamstring. That is on the posterior aspect, right? So now you do the translations. You see, this is the translation. So if there's an anterior glide is more than 5 mm, posterior glide of more than 5 mm. So this is the positive test. And then comes your meniscus. So the meniscus are nothing but these are the two important meniscus. So this is your lateral meniscus. This is your medial meniscus. So what you have to remember here is the medial meniscus is said to be less mobile, right? Hence more prone to injury, right? It is more prone to injury. And now your LCL, why it is less mobile and more prone to injury? Because it is attached to your MCL. It is attached to your MCL. So that is why it is less mobile. And now it is more prone for injury, right? And LCL, if you see, it is a cord-like structure. So this is a band-like structure. This is a cord-like structure. And in these two, there is a tendon of popliteus. So this will separate the meniscus with the collateral ligament. Hence, the lateral meniscus is more mobile and it is less prone for injury, right? The two important things you have to remember, right, in case of meniscus. So putting these things in mind, so we have two important tests. So one is the most important McMurray's test. And what is the second one? It is the Epley's grinding test. And the third one, you have your Tesselli's test. So the maneuver is all same. So what you have to remember is, because the medial meniscus is very, very attached to the medial collateral ligament, what you do is you flex the knee joint, right? And then abduct and then external rotate. So on external rotation and abduction, what happens is, so you do abduction. So first what you have to do for McMurray is patient will be on the couch, supine position, and then you catch over the foot of the patient and then you external rotate the foot. After external rotation, you do abduction of the tibia. So this in everything in the flexion position. So you flex and then you external rotate and then you slightly abduct. When you do this abduction and external rotation, there will be stress force which is being produced on the medial meniscus. and now you slightly try to extend it, right? On this extension, whenever you feel pain, if there is a pain, then it is positive for. So whenever you this pain on this maneuver, if you feel, then you say that there is a medial meniscal tear, right? So there is a medial meniscal tear. And again, depending upon the position also, you can tell whether it is an anterior horn tear or posterior. If it is on this flexion itself, he is having mild pain, then you can tell it is a posterior horn. And slightly on extension, if he is having pain, then it is the anterior horn. So similarly, you do flexion, internal rotation. So flexion and internal rotation and adduction. This you do for your lateral meniscus. This is for the lateral meniscus. Similarly, they will have pain. And now the next one is your Apley's compression test. So here what you do, you try to compress. That means pressure downward. And then again you external rotate the foot and internal rotate the foot, right? On external rotation, if you're having pain, it is for the medial meniscus, and internal rotation is for your lateral meniscus. This you have to remember, right? So whenever there is abduction, external rotation, it will cause stress over the medial collateral ligament, and because this medial collateral ligament is attached to the medial meniscus, it will create a suction force for the medial meniscus to um, experience the pain if there are any tears, right? And finally, we have the Thessaly's test. So this is called Thessaly's test. It is again for your meniscus, and this is done on standing on the affected foot. So patient is asked to stand on the affected foot, and now you have to hold the two hands that you give certain support to the patient, and now you do flexion and again external rotation and internal rotation. So whenever they have pain on external internal rotation, again it is a very specific test for the meniscus, right? So you can conclude that there would be some meniscal damage, right? So these are the tests for your cruciates and your meniscus. Now coming to the collateral ligaments. So collateral ligaments, what is there? So you already know they will resist the varus and the valgus force. So there are two important collateral ligaments, that is MCL and LCL. So as you all know, whenever there is an abduction, so abduction is nothing but valgus stress. So you give valgus stress, it is for your MCL, and varus stress is for your LCL. Right? So this is the varus and the valgus stress test. That means if you're moving it towards the medial side. So on the medial side, if you're moving, so this is like this, right? So now you're moving it to the medial side, right? So there is an opening of the lateral segment of the joint, right? Opening of the lateral segment of the joint. That means you are putting pressure on lateral collateral ligament. So that will be painful. And similarly for valgus stress. Valgus stress is you move towards the valgus is nothing but you will move towards away, right? This is valgus. So whenever you're moving away, you will create stress on the medial collateral ligament. So whenever there are tears or whenever certain a problem or pathology in the medial collateral ligament, the patient will have pain. But you also look for pain and opening of the joint. So you have to look for the pain. If it is only pain, then you can tell it is grade 1. And if it is opening up, then it is grade 3. Right? So only pain is there on this movement. It is grade 1 type of collateral ligament damage. The pain and there is opening also on the medial aspect on adduction, on lateral aspect on adduction. Then you can tell it is a grade 3 tear of the collateral ligament. Fine. This is how we do the valgus and the varus. Right? So this is the opening what I was talking about. So this is the opening of the joint. Right? Sometimes if you can't appreciate it, we can also do it under the x-ray. On the x-ray also you see opening of the joints can be felt. So this will be the indication of your collateral ligament damage. Is that clear? So these are all the tests which we do. So That is how you have to put for the knee joint. So whenever you're examining the knee joint, so first you will always start with inspection. So you know what are the points to be written in the inspection, right? There are the 4 points I have told you. So you will write about the first is attitude or the gait. Then you comment on the swelling, then wasting, then skin over the swelling if anything is present, right? And then comes to palpation. We have temperature to talk about in case of infection, then tenderness, right? Then you again comment about the swelling, right? So swelling, if there is anything, you again comment on the swelling, and you can tell about the muscle wasting. So that is how you conclude inspection patient. Then a little about the movements, right? And then test for stability. So there are 3 sets of tests which you have to do for a knee joint. So one is cruciate, collaterals, and meniscus. Not to forget. So always whenever you're concluding, you have to always test for neurovascular status and posterior aspect. Very, very important. That is popliteal fossa, right? And finally, you have to conclude telling the ipsilateral hip joint, whether it is normal, and contralateral knee joint. That is the opposite knee joint, right? So whether it is normal or not. So you have to always conclude with ipsilateral and the ipsilateral hip and the contralateral knee joint. That is one joint above and one joint below. That's it. Okay. So then now you come to the probable diagnosis. So now you come to the probable diagnosis. So once you're done with the diagnosis, so this could be your diagnosis. So it is osteoarthritis of the knee. It could be just a deformity of the knee. So you talk about genu varus or genu valgum. And then you talk about IDK. So you talk about the instability. So which tests are positive? And then if it is a knee effusion, you can talk about whatever, if you feel that it is because of, only hemarthrosis, or there is some effusion which is present, or it is a traumatic effusion, and then there could be a Baker cyst. So these are the possible cases which they give you. And whenever they talk about the valgus, they mainly talk about the intermalleolar distance. So you have to comment on the intermalleolar distance. If it is more than 8 centimeters, it is supposed to be a pathological intermalleolar distance, right? Clear? So you have any doubts? So this is about the examination of the knee joint. And now this is a clinical corner, what we are trying to put up as cases. So whenever you want to study about any case, you can go for this clinical corner, which is there in the app. And then you can search for the particular subjects. For example, if it is orthopedics, then you can select whether you want to read about non-union, malunion, or nerve injuries, or fracture of femur. Every detail is there in that particular app, right? You can explore that library, and you can learn even more from that. Okay, so that's all for today. I hope you have discussed quite a few things. This would be easy, which makes easy for your practicals, right? Okay, Kalai, thank you so much. Any other doubts? Any other students? Anything you want to clarify, if you want to know? So there is always an Insta available for you. So it is on the name of Dr. Alekhya Ortho, right? Or you can follow our PW Meded. So you can directly DM your doubts, right? We will answer you all your queries there. Okay. Thank you so much. See you all again in the next class. Okay. Bye.